Hello everyone, this is Dr. Sam and this video is about pneumonia X-ray reporting. You will learn how to write X-ray reports regarding different cases of pneumonia. We will see different types of pneumonia cases and the report will be written according to the findings on the X-ray. The left image is a normal chest X-ray and the right image will be showing pneumonia cases. The normal image is just for comparison. Here is our first example. This is our first report, starting with the clinical history, evaluation for fever, cough and shortness of breath, suspicion of lower respiratory infection. After the clinical history, we will write the findings, the X-ray findings. These are the findings for this image. Left lower lobe consolidation. There is a focal area of increased opacity in the left lower lobe consistent with consolidation. Air bronchograms are noted within the affected region, suggesting alveolar involvement. No evidence of cavitation or significant mass-like lesion. Cardiac silhouette and mediastinum. Normal size and contour of the heart. Mediastinal structures are within normal limits. The heart and mediastinum appear normal. No significant pleural effusion detected. The left hemidiaphragm appears obscured by the consolidation. The right hemidiaphragm is unremarkable. These were the findings of the pleura and diaphragm. Other lung fields. The right lung appears clear with no evidence of focal consolidation, nodules, or interstitial changes. Bony structures and soft tissues. No acute osseous abnormalities noted. Soft tissue structures are unremarkable. After all the findings are written, you can end the report with the impression: findings are consistent with left lower lobe pneumonia. Clinical correlation is recommended. Follow-up imaging may be considered to ensure resolution after treatment. This is our next example. Clinical history, evaluation for fever, cough and chest discomfort, suspected respiratory pathology. Here are the findings. Right upper lobe consolidation. Dense opacity is present within the right upper lobe of the lung. Air bronchograms are noted within the opacity consistent with alveolar involvement. Bronchovascular markings. There is an increase in the number of bronchovascular markings, suggesting inflammatory or vascular changes. Silhouette sign. There is a loss of definition of the right upper heart border, consistent with the silhouette sign, indicative of adjacent lung pathology. Other lung fields. No focal consolidation, nodule, or mass identified in the left lung or other portions of the right lung. Pleura and diaphragm are normal. The cardiac silhouette is otherwise normal in size and contour. Mediastinal structures appear within normal limits. No acute bony abnormalities detected. Surrounding soft tissues are unremarkable. And here is the impression. Findings are consistent with right upper lobe pneumonia, evidenced by dense opacity, air bronchograms, and associated silhouette sign. Clinical correlation is recommended. Consider follow-up imaging to evaluate response to treatment. This is our next example: clinical history, evaluation for possible pneumonia due to clinical symptoms such as fever, cough, and shortness of breath. Here are the findings. There are patchy airspace opacities in the right perihilar region. These opacities are consistent with consolidation and suggestive of an infectious etiology. The pattern is most compatible with bacterial pneumonia. No evidence of pleural effusion or pneumothorax is identified. The cardiac silhouette is within normal limits. The left lung is clear without any focal abnormalities. Bony structures and soft tissues are unremarkable. This is the impression: right perihilar airspace opacities consistent with bacterial pneumonia. Clinical correlation and follow-up imaging are recommended to assess resolution following treatment. Here is an example of pneumonia involving both lungs. This is the clinical history, evaluation of symptoms consistent with respiratory infection, including fever, cough, and dyspnea. Findings: there are bilateral, peripheral airspace consolidations noted predominantly in the mid and lower lung zones. These opacities are consistent with consolidation and suggestive of pneumonia. The distribution is peripheral, which may correlate with certain infectious or inflammatory processes. The upper lung zones appear clear, and there is no evidence of pleural effusion or pneumothorax. This is the impression: bilateral, peripheral, mid, and lower zonal airspace consolidation opacities, most consistent with pneumonia. Correlation with clinical findings and consideration of further diagnostic workup, such as laboratory testing or follow-up imaging, is advised. Here is another example: clinical indication, evaluation of respiratory symptoms including cough, fever, and chest discomfort. Here are the findings: a peripheral focal opacity in the right middle zone is noted, which may represent focal consolidation or an infectious or inflammatory process. Additionally, there is a focal consolidation in the left middle zone extending into the left base. A linear opacity is noted in the left base. The remainder of the lung fields is clear without evidence of pleural effusion or pneumothorax. The cardiac silhouette is within normal limits in size and contour. Bony structures and soft tissues appear unremarkable. Here is the impression: peripheral focal opacity in the right middle zone, likely representing focal consolidation. Focal consolidation in the left middle zone and base. Correlation with clinical findings and consideration of further imaging or laboratory studies is recommended to confirm the etiology of these findings. This is a case of Lobe pneumonia. Clinical indication: evaluation of respiratory symptoms including fever, cough, and suspected infection. These are the findings. The chest X-ray reveals a focal area of consolidation in the left upper lobe, consistent with Lobe pneumonia. The consolidation appears well demarcated and localized, suggesting an infectious etiology. The remainder of the lung fields shows no significant abnormalities. There is no evidence of pleural effusion or pneumothorax. The cardiac silhouette and mediastinum are within normal limits. The osseous structures and visualized soft tissues are unremarkable. This is the impression, focal area of consolidation in the left upper lobe, findings consistent with lobar pneumonia. Clinical correlation and appropriate treatment are recommended, with follow-up imaging as needed to ensure resolution. Here is a case of right lower lobe pneumonia. Clinical indication: evaluation for pneumonia due to symptoms of fever, cough, and localized chest pain. These are the findings. The chest X-ray demonstrates an area of consolidation in the right lower lobe, consistent with lobar pneumonia. The opacity is well defined and localized, with air bronchograms visible within the affected region, further supporting the diagnosis of an infectious process. The rest of the lung fields are normal. The cardiac silhouette is normal in size and shape. Mediastinal contours are unremarkable. Osseous structures and soft tissues appear within normal limits. Impression: right lower lobe consolidation consistent with lobar pneumonia. Clinical correlation and appropriate antibiotic therapy are recommended. Follow-up imaging may be warranted to assess resolution. This is a case of fungal pneumonia, Pneumocystis jirovecii. It is usually seen in immunocompromised patients, such as HIV patients. Here is the clinical indication: evaluation of progressive dyspnea and suspected opportunistic infection in an immunocompromised patient. These are the findings. The chest X-ray demonstrates diffuse, patchy interstitial and alveolar infiltrates bilaterally, highly concerning for Pneumocystis jirovecii pneumonia. The infiltrates show a bat wing distribution on the left side, which is characteristic of this condition. No pleural effusion or pneumothorax is identified. The cardiac silhouette is within normal limits, and the mediastinum is unremarkable. Bony structures and soft tissues show no abnormalities. This is the impression: diffuse, patchy interstitial and alveolar infiltrates bilaterally, with classic bat wing distribution on the left side, consistent with Pneumocystis jirovecii pneumonia. Clinical correlation and consideration of confirmatory testing, such as induced sputum or bronchoalveolar lavage, are recommended. Here is another case. Clinical indication: evaluation for pulmonary infection in a patient with known HIV infection. These are the findings. The chest X-ray demonstrates subtle consolidation in the mid-zones bilaterally. These findings are suggestive of an infectious or inflammatory process, which may be related to the patient's underlying immunosuppression. The lung bases and apices are clear. No pleural effusion or pneumothorax is identified. The cardiac silhouette and mediastinum are within normal limits. The bony thorax and visualized soft tissues are unremarkable. This is the impression: subtle bilateral mid-zone consolidation in a patient with known HIV infection, concerning for an opportunistic infection. Correlation with clinical findings and consideration of further diagnostic testing, such as sputum analysis or bronchoscopy, are recommended. This is a case of round pneumonia in a 6-year-old child. Clinical history, evaluation of fever, cough, and respiratory symptoms. Findings: the chest X-ray shows a well-circumscribed, round opacity in the middle region of the left lung, consistent with round pneumonia. The lesion appears to represent a localized infectious process, often seen in pediatric or younger patients. No evidence of pleural effusion or pneumothorax is noted. The cardiac silhouette and mediastinum are within normal limits. The remaining lung fields are clear. Bony structures and soft tissues are unremarkable. This is the impression: round opacity in the middle region of the left lung, consistent with round pneumonia. Clinical correlation and appropriate antibiotic therapy are recommended. Follow-up imaging is suggested to ensure resolution. This is a case of atypical pneumonia. Clinical indication: evaluation of persistent cough, shortness of breath, and suspected lower respiratory tract infection or inflammatory lung disease. Findings: the chest radiograph reveals bronchial wall thickening, indicating airway inflammation or irritation. There are heterogeneous opacities, predominantly involving the mid and lower lung zones bilaterally, with symmetrical distribution. These findings suggest a diffuse parenchymal process, such as infection, inflammation, or reactive airway disease. Notably, there is relative sparing of lung apices. The cardiac silhouette and mediastinum are normal in size and contour. No pleural effusion or pneumothorax is detected. The bony thorax and soft tissues appear within normal limits. This is the impression: bronchial wall thickening and bilateral mid and lower lung zone predominant heterogeneous opacities, consistent with a diffuse parenchymal process. Correlation with clinical presentation and consideration of further diagnostic testing, such as CT imaging or laboratory evaluation, are recommended for definitive diagnosis. This case was later confirmed as atypical pneumonia. Now we have a case of cavitating pneumonia. Clinical indication: evaluation of fever, productive cough, and possible complicated pneumonia. Findings: the chest X-ray demonstrates a cavitating lesion in the right middle zone, consistent with cavitating pneumonia. The lesion is suggestive of a necrotizing infection or abscess formation, often associated with bacterial pathogens or aspiration. Surrounding consolidation is noted, further supporting the diagnosis of an infectious process. The remainder of the lung fields is clear. No pleural effusion or pneumothorax is detected. The cardiac silhouette and mediastinal contours are within normal limits. The bony thorax and visualized soft tissues appear unremarkable. This is the impression: cavitating pneumonia in the right middle lung zone. Findings are consistent with necrotizing pneumonia or a pulmonary abscess. Clinical correlation and further diagnostic workup, including sputum cultures and possible CT imaging, are recommended. Here is another case of cavitating pneumonia. Clinical indication: evaluation of fever, productive cough, and concern for complicated pneumonia. Findings: the chest X-ray demonstrates consolidation in the right lower lobe, consistent with acute pneumonia. Within the consolidation, there are internal lucencies noted, suggesting cavitary changes. which may indicate necrotizing pneumonia or abscess formation. The remainder of the lung fields appears clear. No pleural effusion or pneumothorax is identified. The cardiac silhouette and mediastinum are within normal limits. The bony thorax and visualized soft tissues are unremarkable. Here is the impression. Right lower lobe consolidation consistent with acute pneumonia. The presence of internal lucencies suggests cavitary changes, which may indicate necrotizing infection or abscess. Correlation with clinical findings and further diagnostic workup, including CT imaging and microbiologic studies, is recommended. Thank you so much for watching. Please subscribe and stay tuned for more imaging videos.